session, we're actually facilitating.
This meeting is being recorded.
For today's session, we're actually facilitating and hosting from our host site, Mount Vernon. They're going to be doing our case presentation as well. And this is one of the clinics in the East Georgia healthcare system. My name is Kush Desai. I'm an assistant professor at Augusta University. I'm also the clinical director for the Project ECHO for colorectal cancer screening. Dr. Islam and I will be serving as co-facilitators for this TeleECHO session. Just so we can know each other, if you haven't already, please put your name, the name of your clinic, and the role at your clinic, as well as your email address in the chat box, as many people already have. First, let me review today's agenda with you. We'll start with introductions. Then we're going to have a didactic presentation by Gail Sullivan, who's the program director for the New Hampshire colorectal cancer program. We also have a case presentation by Laurie Hutchins from East Georgia Healthcare Center, Mount Vernon Clinic. Then we'll finish with our conclusions. As always, we'll have some introductions, some announcements. You can have the next slide, Lorianne. You can go ahead and change slides. Thank you. And you can do next slide. So this is a Project ECHO. And so Project ECHO is so as we already talked about, the sessions are being recorded. We request that please don't give any patient health information. We do collect registration information as well as chat comments and poll responses. This is for quality improvement as well as evaluation and research. Oh, sorry, we're having some trouble hearing. All right. Hopefully this is better. Let me know in the chat box if you still can't hear me. Next slide, please. Just some general Zoom tips. Remember, keep your mic muted when you're not speaking and unmute when you're speaking. You can always type in questions in the chat screen. We're monitoring that screen. You can also raise your electronic hand if you have any questions. We do love questions, and we want this to be an interactive session. All right. If you do have any technical issues, you can write them into the chat box to Samia and to or to Lorianne. All right. Next, please. Next slide, please. All right. I'm happy to introduce our expert speaker for today. We have Gail Sullivan. She works as a program director for the New Hampshire colorectal cancer screening program, where she's responsible for the overall program management and all aspects of the CDC prevention screening grant. In her past role, Gail was the senior patient navigator and health systems consultant for this screening program. She played a very important role in creating the successful patient navigation program, aspects of which were published by the CDC in a replication manual that are being used today by many of the CDC-funded programs in clinics across the nation, including our own CDC-funded colorectal cancer screening program. Her talk today will be on patient navigation. The presentation will last for 20 minutes. There will be a warning notification by Lorianne when there are 2 minutes left. And then we have about 5 minutes for questions. Gail, you can go ahead and share your presentation, and we look forward to hearing from you.
Great. So I will share my screen. All right, so can you guys see my screen? Great, okay. Well, thank you for having me here. I'm very excited to present on our very successful New Hampshire colorectal cancer screening program patient navigation model. You'll see that we shorten our name to the acronyms that are in the parentheses there, which is NHCRCSP, and we refer to ourselves fondly as New Hampshire CRSP. So you'll hear me refer to it. Again, my name is Gail, and I'm the program director for this program. So as you all know, I'm sure already, colorectal cancer is the second most common cause of death from cancer in the United States. We also know that colorectal cancer can be prevented through screening and early detected to prolong survival with the disease. But despite these compelling evidence for colorectal cancer screening, rates nationally remain low. So through a CDC-funded grant back in 2010, we were allowed to pay for low-income or underinsured New Hampshire patient screening colonoscopies. When patients came into our program, they were assigned a patient navigator who navigated them through the entire process till completion of their screening. Patients were navigated through, like I said, the whole thing. The navigators made sure they were medically appropriate for the test, that the patients would understand the test and the preparation for it. They would get their results and understand them and the recommended follow-up, and barriers were addressed throughout the whole process. So barriers to colonoscopy. So to back up for a bit, what is navigation? So navigation is defined as individualized assistance to support patients by identifying and addressing any barriers to complete their screening. Here we have listed some potential barriers. You'll always hear more or less. It can be cultural or social issues. There can be lack of knowledge, language barriers, practical issues such as transportation. They need someone to accompany them home, and obtaining the prep and understanding and taking the prep correctly so they're successful. And then again, like I said, receiving their test results and the recommendations from the provider, the follow-up recommendations, I should say.
Gail, I don't know if the slides are moving. We're only seeing the title slide.
Really? Okay, it says I'm sharing.
Yeah, that one we can see. Are you, let me see.
What do you see on my screen now?
We just see the title slide, which you initially showed.
Okay.
We have the slide presentation on our screen. If you want us to share it, you can just let us know when to do the next slide, if that works.
You know, maybe that's the best, because I'm not sure why. I'm advancing my own slides, but you guys can't see them, is what you're saying.
Not sure. Yeah, but that's okay. We have them. So Laurie, if you can go ahead and share your our presentation.
I apologize for that. I can start
okay.
back where you. Never in my background did you hear anything about technical abilities.
No
Okay.
worries.
All right. So we're on the first slide.
Yep, we're on the first slide. We're on the title slide right now.
Okay, so you guys saw that. You saw the rationale. You heard me say the rationale, right? For colorectal cancer screening, which I'm sure you already know. Next slide. Okay, I don't know if you heard this part, but we were a CDC funded grant back in 2010, and we were allowed to provide, we had a grant that allowed us to pay for screening colonoscopies for low income, underinsured New Hampshire patients for their screening colonoscopy. And patients that came into our program were assigned a patient navigator that navigated them through the program. So the patients that were navigated through the process, the navigators made sure they were medically appropriate, they understood the test, the results, the recommended follow-up, and the barriers were addressed through the whole process. Next slide. Okay, so barriers to colonoscopy. So I don't know if you heard me say about navigation, what the explanation of the definition of navigation is: to assist and support patients by identifying and addressing barriers to their screening and through their screening. And here's a list of potential barriers, which is where I think you guys didn't see this slide. So there can be cultural barriers, lack of knowledge of the screening itself, any language barriers, practical issues such as transportation. I think you heard me say, you know, the colonoscopy, as you know, you need to have someone accompany you home. There were barriers to getting the prep for the test and taking the prep, and then results and recommendation, understanding follow-up from the provider. So next slide. Okay, is everybody caught up? I just don't want to I want to make sure everybody, it's flowing okay now. Yes? Okay, thank you. Okay, so was patient navigation successful or effective, I should say? So here you see some of the outcomes from this program. We navigated 2,000 low-income, uninsured or underinsured patients. There was a 0.1% no-show rate, so meaning 2 out of 2,000. There was less than 1% inadequate preparation. 100% of the patients and their primary care providers received the colonoscopy report and the follow-up recommendations, which if you're providers out there, you know how hard that is to get. And sometimes, and we always had a patient satisfaction survey that went out, and it always came back they were very happy with the program. Next slide. So because of those results we just showed, the CDC and the New Hampshire CRSP program compared navigated and non-navigated patients at one site. These are the results of the comparison study. So navigated patients were 11 times more likely to complete the colonoscopy. They're 40 times less likely to miss the appointment, and 6 times more likely to have an adequate bowel prep than non-navigated patients. Next slide. So core elements. So what are core elements? There are certain elements that are essential in order to make this model successful. We call them core elements. There are 7 core elements in this navigation model. We strongly encourage if you want to replicate this patient navigation model with fidelity. If not, it may not be as effective. Next slide. So core element 1, the nurse navigators. The nurse navigators are the heart of the model. In our program, the navigation was done telephonically because it was a statewide program. So the nurses couldn't meet the patients in person. We hired registered nurses because of their clinical expertise. They had psychosocial assessment skills, and with their clinical expertise also, they could recognize and resolve patient barriers. So next slide. Core element 2, a patient navigation champion with clinical expertise. So you want a patient navigation champion with clinical expertise and leadership. It's a vital point because you want to have an advocate to implement the model. Some of the qualities they should have is leadership and expertise with CRC screening. Next slide. Core element 3, medical oversight of the navigation intervention. This champion should be able to provide expertise to the navigators, engage providers, and provide clinical oversight for the whole program. Again, it's good to have a door opener to engage the providers at the sites. So next slide. Core element 4, partnerships. You want to develop partnerships with internal champions to improve communication, which will improve patient care. Next slide. Sorry, I get distracted for a minute there. Okay, core element 5. This is important. The 6-topic navigation protocol is important because it's not about the number of calls you make to a patient. It's about the topic. You want to make sure you cover these 6 topics. The first topic being the first topic, which is usually the first call. Introduce the program to the patient. The second protocol would be the prep education. Oh, I'm sorry, is someone have a question? Oh, I'm sorry, I could hear something. The second topic protocol would be prep education and start to resolve any barriers the patient has. The third topic protocol, start to review the prep a few days before the scheduled test. The fourth call would be to call them the night before, see how they're doing with the prep, answer any questions they may have. No, you can't have a glass of wine. It's not considered a clear liquid when you're doing the prep for colonoscopy. I hate to tell you. And then the 5th one was day of the colonoscopy test, see how they did. Was it completed? How they're feeling? And then the 6th one was to discuss the outcomes and the follow-up recommendations. So next slide, please. So core element 6 is to have an effective data system. Because we were a grant-funded program, we had to report data to the CDC. So we set up the secure data system to collect all the information we needed on each patient. What this did as well, it gave us, we could monitor, do some QI work within our program and evaluate our program, see if we needed to make any changes. It was a real-time data system. So that's what allowed us to track and monitor the outcomes we showed earlier. And the biggest part of it was a communication tool with our team. So at any time you could go in and see exactly where a patient was during this process. Next slide. So core element 7, the philosophy of shared success. So this is the guiding principle of the whole model. This helps patients take charge of their overall health by guiding them to resources they may need. And because navigated patients were better prepared to take a more active role in their overall health care. Meaning if they needed help quitting smoking, the navigator would get them to a quit smoking line that you may have in your state. If we were women and they hadn't been screened for breast or cervical cancer yet, you could give them the contact at the local CCP program. So, and that was very helpful to the patients with their overall health care. Next slide. This is blurry, I apologize, but this is what you see here. These are the 7 core elements we found essential, the 7 circles. The CDC and the New Hampshire CRSP developed a replication manual that you're looking at that provides the details of the model. Again, the 7 circles each represent the core elements. If you look at the middle circle, you see the 2 hands shaking, and that represents the patient and the navigator with equal partners to getting the patient through and to complete their screening, their colonoscopy. So next slide. So again, here is the website. If you want to download the manual, share it with your colleagues and friends. Here is our email at the New Hampshire CRSP if you have any questions and suggestions. And I thank you for letting me present on this.
Thank you. That was a great presentation, Gail, and I especially was impressed with the statistics that you guys did with the 11 times more likely to get screened. That's extremely impressive numbers that you were able to share with us. Does anybody have any questions for Gail? Laurie, you can put it back on that. Yep, if you want to put it back on the statistics slide. But do any of our providers out in the field have any questions for Gail? I can go ahead and get started with a question as you guys are thinking of others. So I'm just interested in the sustainability. So we talked about there was the slide right here says there's 2,000 colonoscopies as part of the grant. After the grant had completed, were you guys able to continue navigating, and did you guys see similar results after the grant period was completed?
So once that grant was completed in 2015, we applied for the next round of grant funding, and the focus had changed with that. Because of the same time what happened was the Affordable Care Act came out. So the idea was that everybody had insurance or some type of coverage. So they pivoted the focus of the grants to a more health system type focus, which some of you here on the call may have had. So that's where we kind of switched over to the health system consultant, worked with health systems as a whole, increasing their screenings. And we worked with multiple partners at that time. So to answer your question, we didn't have the funding to actually pay for people's colonoscopies, but we always took a heart of this model, and I did, especially because I was a patient navigator at one time. You know, I worked with case managers, I worked with community health workers in that next rounding, helping them do outreach to patients, kind of mentoring them on how to talk to patients about completing their screenings. I did a lot of motivational interviewing with them. So that was a good part of that grant. So we could continue our work, but in a different way, if that answers your question.
Gotcha. Yep, that's interesting. So I think Dr. Hotz has some questions. He has a question and a comment.
Yeah, these are phenomenal numbers, and I have read through the manual from the CDC. And just to make a comment, I chair the Community Health Center Committee of the National Roundtable. The no-shows after a positive fit, and a lot of us are doing after positive fit, is over 50%. we had our state committee, our access committee, which looks at trying to link, people under 250% of poverty. And the biggest issue that our gastroenterologist said that the CDC project in Georgia could help with is navigation, was their number one thing. At Grady, the no-show rate was over 30%, and even in private practices, 10 to 15% no-show rate was very common. In addition to polar bowel prep was greater than 10%. So, a well-run program like yours makes a real difference. And we've seen that in Horizons have been able to successfully navigate 95%, but I think we could all learn a little bit from what you're doing. The big question I have right now that drives me nuts is trying to get that final recommendation from the gastroenterologist, because usually we get back colonoscopy completed, 5 polyps removed, final recommendation pending path. And over 50% of our people, we never get that final recommendation, nor does the patient. How did you accomplish that? Because also on a national level, if you ask, the biggest complaint that community health centers have is, even when we get them there, we can't get the damn report. How did you do that?
I'm telling you right now, the one thing that's there's so many important factors in here, like we talk about the core elements, having a champion at every location. I always had someone not behind the scenes, but someone I could call on the phone to say, I have this patient, she knows her results, he or she knows the results. I just called the provider office because we always did that. Did you get the results? No, we didn't. So we tried to make it so that workflow processes started to go in place. And that's what we left with. So we would have this champion, we'd work with them. What's the best workflow process for you, for the receiving provider site? And we would start to implement those workflow processes. So it's really about having a champion, buy-in, and getting those workflow processes in place.
And the final comment is, and I've spoke with Dr. Lynn Butterly, who helped with the monograph and been active in the National Roundtable. And, one of the things she always points out is, the importance of having the endoscopist engaged and, knowing what the rules are as far as quality reporting. And it seems like that you've been able to incorporate these things into this program. Have you been able to increase the screening rates in the state? Have you noticed your numbers going up through the efforts you're doing?
We have, since we started in 2009, and we're in our 3rd year rounding here, because the first one was a 1-year grant, and now we're in the 3rd 5-year grant, and the numbers have gone up significantly. I think we're over 70% as a state right now, which I don't want to say out loud because I want to continue to get funding to keep this program going. But yeah, we've done a lot. I think, as a team, all of us, and Lynn being the heart of it, she's the PI on this grant and has been, and I've learned so much from her, and having her, and that's what I consider a door opener. Because when to this day, and we're taking on new partners now, and I say, I have a gastroenterologist that's the head of colorectal cancer screening at Dartmouth, can come and do a presentation to your providers on high quality and how to know which test to recommend. That's great. That opens a lot of doors for us. So.
Okay, thank you.
Thank you.
Yeah, thank you, Dr. Hutz. So another question we have from in the chat box is, what were the demographics? I think they mean the demographics of the patients navigated. We have that information.
I don't have it in front of me. We did collect that we definitely have that information in our secure data system. So we had all the demographics.
But I'm assuming there's a lot of uninsured patients because that was the grant, the grant was focused on uninsured patients. So. Okay,
so back in that grant, which was 2010 to 15, there was a lot of uninsured people in New Hampshire. It was before we became a Medicaid expansion state. So we did have a lot with 2,000 people that came into our program to get through a screening colonoscopy.
Yeah, so these are a lot of uninsured patients that you guys have successfully navigated. So that's
They were all, yeah, they were all definitely uninsured or underinsured. And, you know, we also would get patients that referred to us that didn't, we had criteria. It had to be a screening colonoscopy. It couldn't be a diagnostic. We would still help those people. We just didn't collect data on them. So we never left anybody out there. Like if someone called and said, I really, you know, my brother died at 50 of colon cancer and I have to have it, you know, or not that, you know, but someone who had symptoms that needed a diagnostic versus what would be considered a screening. You know, they wouldn't be accepted into our program because we were screening only, but we would help find funding for them through a health care system that might have compensated care. So we worked with a lot of patients in New Hampshire.
That's awesome. We have a question, a little bit more time, so we could, Cheryl has a question, it looks like.
Yes, Gail, outstanding statistics and congratulations on sustainable funding over 3 grant cycles. That's really terrific. My question is, now that we've been through COVID and nurses are a commodity that may be difficult to employ as navigators, have you looked at lay navigators? And specifically, our head of our, we have an advanced practice nurse who oversees the Cancer Patient Navigators of Georgia program that we run through Georgia Core. And we've reached out to a potential partner up at Georgia Gwinnett College, where they are actually providing a degree for patient navigation. So can you talk about a changing workforce, since nurses may be hard to secure for this, and how that could be incorporated in such a successful program? Thank you again, outstanding work.
Oh, you're welcome. Yeah, it's hard. So just so you know, now the grant that we're in now, we aren't paying for anyone's colonoscopies, and we weren't in the last round. So this was the very first round of grant funding that allowed us to do that, and that allowed us to put navigators in place. And so back then I was a navigator, and I'm a nurse by trade. So it was telephonic. It was a lot, you know, at the time that for me was because it was based out of my home, was very attractive at the time. Now, like I said, the last round of grant funding, we didn't have any navigators, but I worked as a health system consultant with community health workers, and I helped them essentially become patient navigators with everything I knew with my expertise. So I would meet with them and mentor, like I was saying, that with the funding that we're in currently, we can't pay for people that are having screening colonoscopy. Like Dr. Hutch was saying, we can pay for someone that has a positive stool test that needs a follow-up, that has to have a follow-up colonoscopy, but they're uninsured. We can pay for those. And on staff, we do have a nurse navigator. And not only does she navigate those patients, but she navigates any of our partners' patients to whatever test they're having. So even if someone has been ordered a stool test, but the provider is saying, I can't even get them to do that, they just refer them to our program. Our navigator takes it from there, and she follows these core elements. And you know, she's been successful getting people screened as well. So did I answer your question? I feel like I went off on a little bit. How you want to know how you get nurses? You know, everybody takes a job, right, to what's important to them at the time. So, you know, you want to target maybe a group that is, you know, not looking for, you know, that intense, I want to be in the ICU type nursing or whatever. You want someone who's been through a lot. You want someone with a lot of expertise too. I would always recommend hiring navigators that have been through have been through floor nursing, some type of nursing, and now they want to just help people get someone through. So, yeah, I don't know if I answered your question, but that's how we did it.
Awesome. Thank you for that information. So a little bit more time, and then we're going to get started with our next presentation. One more question I'm seeing from the chat box is, what is the referral path? Do clinics refer patients to you, and do you take it from there? Do clinics reach out to navigators, or do you have a patient navigator assigned to each clinic?
Okay, so that's a great question. I'm sorry, I'm leaning because I'm having a hard time hearing you. I think the question was, and I think it's directed to the grant we're in now, which is very different than the grant where we had 2,000 patients in our program. So the grant now, the clinics refer their patients to us, and we take it from there. And that's how it was years ago when they were referring patients. Well, actually, a patient could refer themselves if they heard about our program and they had no insurance. That was one thing we did too, which I don't know if I mentioned. They would call us up. They'd say, I have no insurance. I'm uninsured. I have to have a colonoscopy. I need a screening colonoscopy. And then we would get them into a health system. So we would get them connected to a primary care provider if they didn't have one. So we did do that as well.
Very good.
I just want to add one thing before I end. And this model can be used for other types of screening as well. And you can even use this to get diabetics back in for their A1Cs. You really can tailor make this to whatever population you're trying to focus on getting back in to your clinics.
Awesome. Thank you, Gail. Now we're going to move on to our case presentation for today. Our case presenter is Laurie Hutchins. She's a family nurse practitioner at the East Georgia Healthcare Center. The East Georgia Healthcare Center started about a year ago in this CDC-funded screening program. Laurie has been very successful in getting a lot of patients screened and increasing her numbers, her screening numbers. So she's going to tell us a little bit about that. We also have Steve Monty, who's one of the MAs here at this clinic, and Sable, who's the clinical liaison for the grant based out of East Georgia. Her presentation is titled Implementation Updates from Mount Vernon Clinic. We have 10 minutes for the case topic discussion and 10 minutes for question and answers. There will be a warning notification by Laurie Ann when you have 2 minutes remaining, and let us know when you want the slide changed.
Hi guys, I'm Laurie Hutchins. I'm a nurse practitioner here in Mount Vernon, Georgia, and I'm going to just give you guys some updates on the screening process in our clinic. Next slide, please. So the first slide that you're looking at, this is just basic demographics for the clinic that we see here. This is a population of patients seen in 2021 and the first half of 2022. One of the interesting things about this slide is you can see that our population of insured versus uninsured is actually, we see a few more insured patients than uninsured patients in this particular clinic. Next slide, please. The next slide that you're looking at here is demographic data of our colorectal screening rates. On the left hand of this side of the screen, you see colorectal screening rates from January to December of 2021. We were at 52%. And then from January 1, 2022 to July 31st, 2022, we did have an increase in our colorectal screening rate at 61%. Again, if you look at the demographics here, we tend to be more successful at obtaining colorectal screenings with our insured patients versus our uninsured patients, although there was some improvement from 2021 to 2022. Next slide, please. And again, this is just a graph showing from the beginning of implementation with CORE from October 2021 to now. You can see where we started at colorectal screenings and that we have had pretty significant improvements in our screening rates from 2021 to the present time. Next slide, please. So I'll just briefly go through the screening process for colorectal cancer screening and how this works in our office. The first step is that our medical assistant here pre-screens all of the charts for and notes patients who are eligible for colorectal cancer screening. Once the patient comes into the office for the appointment, the MA actually discusses colorectal cancer screening during the triage process. If the patient is willing to accept the HemoSure kit, the MA goes ahead during that triage process, explains how to collect the sample and return the HemoSure, and the HemoSure is provided to the patient. If the patient at that point refuses the screening, the MA will come to the provider, which is me here in the office, and notify me that the patient has declined the colorectal cancer screening. I, at that point, usually whether the patient has accepted the screening or declined it, will reiterate the importance of screening in the office. Most of the time, if the patient has declined the screening to the medical assistant, once we've discussed it throughout the visit, they'll agree to at least take the kit. And then at that point, Horizon starts to navigate the patient. Next slide, please. Some of the barriers that we found in our particular clinic to colorectal cancer screening are there are patients who are just uncomfortable about the process. They don't like collecting a stool sample. They don't want to have to deal with that. They don't want to have to return it to the office. Some of our patients tell us that they lose the kit or they forgot it. And then one of the other, and probably one of the biggest barriers to colorectal cancer screening is health illiteracy. Medically non-compliant patients are much more likely to not complete the screening process. We've seen that time and time again. Patients who don't manage their diabetes well, patients who don't manage their blood pressure well, patients who miss appointments, patients who don't take their medicines will oftentimes not complete the screening process. Next slide, please. And then some of the reasons for success for colorectal cancer screening in our clinic. We have a strong multidisciplinary team. It starts with the medical assistant screening the chart, then to the provider, multiple discussions with the patient by different people in the clinic, and then going on to the navigation process. Next slide, please. Next slide, please. And this is just a discussion question for the group. What processes do your clinics have to ensure that patients are getting screened and they're identified for screening?
So we have any other providers from other clinics around the state and around the country that are on the call. What do you guys do? We talked a little bit about what Laurie's clinic does. And it sounds like a big part of their success is their MAs identifying patients and providers, multiple reminders for the patient from the provider to MA and then again, ultimately the navigator. So what are some processes that other clinics have used? And so do we have any other any clinics in the audience that they use? Let's see. So, Dr. Hutch, what do you guys do in Albany at APHC? What are some processes that you guys have employed over there?
Yeah, it's interesting you bring that up because that was a topic of a conversation yesterday as we go through our workflows. We have a navigator, much like a medical assistant, who goes through the charts, preps the charts, puts them in the huddle, and says who needs to be done. The issues we've come up is, if you have the MA do it, that's fine, but we've been trying to figure out how do you notify somebody when it's due. In eClinical Works that a lot of us have, there's this thing called the sticky note section, and we've been putting them in the purple sticky notes, but not everybody reads them. And then once you've done a notice, how do you take it down? So, a workflow, and we're gonna continue doing that. But having somebody work the chart, find that is an issue. But it does work if you properly notify the provider and if the prior provider gets engaged. And we have clinics that vary in the success of that, and trying to get 30 clinics to do all the same thing is a challenge. So that is one of the ways that we've been successful doing that. But one of the challenges we've run into is that not everybody is average risk. And so there are probably 15% of people who should not get a FIT test because of family history, past history of polyps, they've got Crohn's disease, various reasons. And I guess my question back is, how do, using this medical assistance model, how do you identify people that are at higher risk?
Do you guys screen the charts the day before, or how do you guys do it?
We do. We screen the charts the day before, and you may be able to answer this better than me. If the patient has already had a colonoscopy previously, if they have a history of colon cancer, colon polyps, then they are not identified as being eligible for a HemoSure screening.
And where do you document that in the chart? Is that in the problem list, or, so that somebody doesn't have to dig through that every time? Is there a best practice you have?
we actually have a paper form that is provided to the medical provider and the medical assistant. It's called a huddle sheet. So it lists every patient that's coming in that day and what screening tests that they're due for. I know that I and my medical assistants here utilize that huddle sheet as one of the first line things that we look at to determine, do I need to look through this chart and ensure that this patient is appropriate for the screening. And then it's also documented in our notes, in the bottom of the note under preventive medicine and ECW, if the patient was appropriate and accepted the kits.
Okay, thank you.
Awesome. Any other clinics? I know we have a lot of other providers. I'm just looking through that that are part of the program. What are some other processes that other clinics have used to identify patients and help get them screened? We've also seen successes in Swainsboro. They've done a great job also. They've presented as well previously. What are some things that you guys do to get those patients identified? I think Dr. Sullivan's trying to talk, but it's muted, maybe. Let's see if I'm not muted. Sorry, it's still muted. And any other clinics as we, I'm not sure why it's still muted.
There we go. I'm unmuted.
There we go.
Okay. We too have initiated a team huddle approach where the physician and the MA work together, kind of review who needs a colorectal screening. We also take the time to catch what other screenings they might need as well. And then I think it's to the lead of the provider, essentially, you know, to identify if they're higher risk. But frankly, the more we do it, you know, my AMA would chime in, oh, they've had a colonoscopy, so, you know, I think sometimes the difficult piece is to track down the medical records, you know, and make sure that we have, it's not just the patient saying they had a colonoscopy, but we have the goods, if you will, in our patient documents. So I think as we just spend a little more time looking at the patients and what screenings they need, including colorectal, we get a better sense of whether they need it or not. You know, the biggest number of high risk are those who've had prior colonoscopies with a polyp that need a second colonoscopy, obviously, and not the FIT test. You know, that's kind of the model that Laurie has used. We used now at many of our clinics here throughout East Georgia Healthcare Center. And I'd be curious to see what other providers as well are doing.
Yeah, it seems like that model is helping and working. So it looks like somebody, Nuhu in the chat, some of our partner clinics here in MO, Missouri, utilize pre-visit planning in DRBS, and they review them during the morning hours. Nuha, do you want to explain that a little bit? I think that's a really interesting model that you guys are using out there.
Yes. Hello. My name is Naha Warra. I'm a practice facilitator of the Missouri CRC screening program. So we work with FQHCs in rural Missouri, and a lot of them, or all of them, they utilize Drbs software, which is provided from Azara Healthcare and through contract with the Primary Healthcare Association. So these softwares, they are kind of integrated into their HR, and they work in the background of their HR, and they can pull data much easier than using their HR. Like I said, a lot of our clinics, they utilize the pre-visit planning sheet in Drbs. So they can just pull that the day before the visit, and it outlines the patients, and if they have a healthcare gap, they need any of the preventative services, including colorectal cancer screening. You'll have the age, their medical problems, and past medical history, everything in one sheet. So they can have one sheet to discuss together during the huddle and make sure that the patient is needing the screening or not.
That's good, yeah. It seems like all of the clinics that are in the program that have been successful are using some type of pre-visit planning type of system where they're able to identify those patients. That seems like that's a common theme that we're seeing here. Another common thing we're seeing is kind of circling back is patient navigation. It seems like most of our programs and clinics are using those patient navigators, and it seems to be pretty successful. What about any other barriers? Have you seen, I mean, we're talking about the successes here, but what are some barriers to screening that we're seeing and from some clinics around? I think Dr. Sheldon identified one key barrier is that actually tracking down records from providers. And I think at the beginning, as we were getting on the call, Kyle, who's from Swainsboro, identified that at one of the big health systems here, they're getting access to records there remotely. So I think that's kind of one way to overcome that particular barrier. Are there any other barriers that we're seeing out in the field as far as to getting patients screened?
Yeah, this is Dr. Vance. I'm with AAPHC like Dr. Hotz, and one of the logistical problems we've had is when patients mail the fit test back, we never get them, or the LabCorp never gets them. And I think that has something to do with the U.S. Postal Service more than anything else. You know, I know the Postal Service has been, you know, impaired or understaffed. And unfortunately, I think it's delaying fit test returns or losing them altogether.
Interesting. Are you all resending those out, or how are you guys handling that?
At my specific clinic, our phlebotomist actually has gone out of her way to ask patients to just physically bring them in to our offices. And, you know, that helps. But, you know, obviously, we go back to the barrier of transportation. If patients have transportation problems to begin with, you know, the mail system not working the way it should keeps that a problem. So we don't get all the fit tests back, probably because of that.
Interesting. Yeah, that's an important barrier. Does anybody have any other ones? If not, we can go ahead and start summarizing some of the key points here. We have one more. It says, anybody willing to share? And this is in the chat. Anybody willing to share if you touch on screenings and any other patient visit or just annual visits? Some providers are hesitant to do so with time barriers. If any visit, how do you encourage this? That is an important question. And time is a big constraint, even, you know, that's something that all the providers talk about. So you could start, Laurie. How do you guys handle it?
Sure. I know from my standpoint, I usually try to do it at the end of the visit. What I'll address first is the patient's main concern for the reason that they're seeing me today, whether that be follow-up for diabetes, blood pressure, or a sick visit, whatever their current problems are. And then usually at the end of the visit, I'll just take 2 or 3 minutes and do a brief overview with them of, you know, preventive healthcare is important. This is the reason I'm talking to you about this. This is the reason for colorectal cancer screening, and, you know, ask them if they have any questions. And I found that it doesn't really limit me much in time if I just focus that portion at the end of each of their visits.
Yeah, that's a really organized way of doing it. And I think one that, at least when I was doing a lot of clinic, that's something that we would try to do at the very end. We had a list of things similar, because from a pre-visit thing, I have a list, let's just quickly go through these, and the more times patients hear them, the more likely they are to, maybe not this visit, maybe the next
time we'll discuss that.
That's a great thing. There was a question from Terry Wood about, are these fit return envelopes paid postage? So for patients that are in the grant, or for clinics that are in the grant from East Georgia or at AAPHC in Georgia, in our program, they are paid postage. And that's something that the grant, the CDC pays for. All right, and Mary Beth Curtis says, thank you, Laurie. Very good. So any other last minute comments before we do some quick summary of what we've heard today? Any other comments from the providers or any other anybody else on the call?
Just to reinforce the fact that, and we gave this in an ECHO project 2 months ago. Yes, we with Horizons now navigate the fit tests back, and we are running into some of the mailing problems, but non-navigated return rate was around 30%, and navigated is about 70%. And I saw our colleagues in New Hampshire also were getting involved in navigating the fit test. So I think that's something to remember, that they can navigate not just getting to the colonoscopy, but actually navigating that test coming back.
Very good. Thank you, Dr. Haas. So just some quick
Kush,
sorry, go ahead.
Kush, I do have one question, and this question is for Gail. Given that we're talking about the clinics on the clinic level, the health systems, and we're also meeting here a lot of providers, she did mention that we have you guys use the patient satisfaction survey. At least that was an opportunity for you to hear from the patients, right? So if you could talk a little bit about that, how did you distribute that to the patients, and if you're using it now in your current grant?
So yes and yes.
Good,
So
good.
we would send out a card that we had created that said, thank you for taking care of your health and getting screened. Here's a couple of questions if you don't mind answering for us. Now we send them again a card, and I believe, I'd have to check with my nurse navigator. I think it's a link that they go on to and they fill out themselves. But I think it comes back in snail mail. I think it is something that they fill out, but great question. I'll find out the answer to that, but we do still track that.
And then to find out also the response rate, how many people actually sent it back? I would be interested in that too.
Yeah, we don't I do have that from the last grant that I just from the model that I presented on. I don't have it in front of me. Can always send it to you afterwards, and we are tracking it currently.
Thank you.
I want to say it's pretty high. It's pretty high up there. So
that's good. Thank you so much.
You're welcome.
Thank you, Lorianne. Dr. Islam, do you have any other comments or questions? Last minute comments or question to add?
No, there is no other questions from the chat, and I do not have any further follow-up questions. Thank you.
Very good. So some key points to summarize our session for today. We learned that patient navigation is extremely critical to getting patients to return their test back or to report to the colonoscopies. We also learned from Laurie that using this Laurie and others actually using this pre-visit huddle and pre-visit screening of the chart is also critical in identifying which patients are eligible not just for colorectal cancer screening, but all their screenings in preventive healthcare. We also saw something I was very interested in the data that Laurie presented, was that so her insured patients did, after implementing this pre-huddle screening as well as patient navigation, their insured patients did get higher screening rates, went about 58 to 65%, but her uninsured patients actually saw the biggest increase from about 28% to 45%. So while they didn't get to the same level as her insured patients, we saw the biggest increase in uninsured patients after implementing these processes and implementing patient navigation. And so the key takeaway today, I would say, is the value of patient navigation, and also the value of a pre-visit screening of charts and huddles is kind of some of the key points that we learned today. And so that concludes the presentation for today. Maniro?
Oh, thank you so much. well, I wanted to thank you, Laurie Hutchins and Gail Sullivan for your presentation. And I wanted to take the opportunity that a special thanks to Gail, not only for running a successful program in New Hampshire, but also extending their supporting hands to the other states' CDC-funded projects. And we are one of the beneficiaries. Thank you for that. And I have few useful information for today's participants and also participants for our future CRC colorectal screening session, echo sessions. Participants for today's sessions are eligible for CME and CNE credits. If you want to claim your CME credits or CNE credits, please follow the link posted in the chat sessions or scan the QR code. Moving forward, we will need volunteers to present case studies in our future sessions. If anyone has a particular case would like to bring up, please let email at au_crcscreening@augusta.edu. Our next session would be Wednesday, October 5th, 2022. We will share flyers with the information for the next session within next 2 weeks. Thank you everyone for attending today, and we see you at our next sessions. Have a good week. Thank you everyone.
Thanks everybody. See everybody next time.
Bye-bye.
Usually stay on.